Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect Podcast here at Countryside Equine Hospital. I'm your host, Dan Carter. I don't know why I always say the host. So
you are, though. You're the host. When you're not here, we're the host.
I guess so, yeah.
Yeah.
So I'm your host. I've got Dr. Caitlin back with me.
Yep.
So
Hello.
How are you doing this morning?
I'm vertical. Sometimes that's all you can ask for.
You know, that happens.
It does. It's all right. We're working with it.
But you know, I still remember every day. We don't have a real job.
We don't. We really don't.
I'm pretty excited about that still.
Yeah.
So we're back around to kidney. I guess it's technically kidney part 3.
Yep.
What happens when the kidney goes bad?
Nothing good.
You know, the downside of the kidney, like the kidney is this incredible organ, right?
It really is.
Literally tied to everything. I always say it's the brainchild of metabolic function.
If you didn't catch part 1, you need to go back to part 1 where we talk about all of the, not even all of the things, but the biggest things that the kidneys do.
Right. And you learn like this thing really is the brain of the organ systems.
Yeah.
I mean, it literally is involved in everything.
It keeps the environment stable so that the rest of the organs can function and live.
Yes.
That's its job.
It's cool.
It's really cool.
Downside, when it goes bad,
it goes really bad.
Everybody suffers.
Yeah. And the kidneys are such a little workhorse that they will compensate and compensate and compensate and compensate so that we don't even know that it's bad until it's really, really bad.
Well, you know, I think this is the worst statistic in all of medicine.
Yeah.
You have to lose 75% of your kidney function.
It's a whole kidney and a half.
A kidney. I never really thought about it that way. It's a kidney and a half.
It's a kidney and a half.
Before you start to see a rise in kidney values.
Yes. It hides it very, very well.
I mean, how many millions of nephrons do you have to lose before the kidney's like, guys, I'm not feeling great.
Yeah. They're like, I just can't do it anymore.
It's incredible.
It is.
But it's terrible at the same time because we're always late to the party on kidney disease.
Mm-hmm. And there's, in human medicine and in small animal medicine, they're coming out with some earlier indicators for kidney function and, kidney damage. But in equine medicine, we're just not there.
No, I mean, I remember when SDMA came out, we were one of the trial hospitals where they were running these free SDMAs on all of our blood work. And it's a great indicator in cats because cats have the same problem. They like to get kidney disease.
Cats love to get kidney disease.
And they're looking for an early telltale, and they found this SDMA enzyme, and that's been fantastic. Mm-hmm. It didn't do anything in horses.
No. And the hard part about horses, too, is just their sheer size and their blood volume to manage kidney disease. And people, they get, dialysis, and dogs and cats, they can get sub-Q fluids regularly. You can do that at home. Horses' blood volume is so big, to diurese them or to flush out those kidneys, you've got to have like hundreds of liters of fluids.
Yes.
So it's not something that you can just do in your living room like you do with your cat. Like it's a whole different ball game.
Because I mean, cats, you send them home with a bag of fluids. You're like, here, put this underneath the skin.
Give them a little bubble every couple days, and you'll be rocking and rolling, good to go.
Do fantastic.
Can't do that in horses.
No, you cannot. So we're going to talk about what happens when it goes bad today. We're going to talk about the kidney isn't working. There's different forms, different causes, and then sort of what we do to help these guys out when we do start to see it.
Yeah.
So let's start off. What's the first thing? Like, let's talk about some early indicators of like, hey, my kidneys aren't working.
Yeah. So we look at a lot of some blood values on our normal lab work will kind of key us in, but also just looking at the horse overall first is saying like, they're just kind of ill-thrifty. They'll lose weight. They have a dull hair coat. They might be drinking and urinating a lot. They're just not right. And we've kind of ruled other things out on the list. Like, do you have intestinal parasites? Do you have gastric ulcers? Is your nutrition plan not working? Like, we've kind of worked through a lot of these things And then we back ourselves into a corner of like, well, what else could it be? And because kidneys are so tied to everything, you get all of these other changes in the horse that kind of show that they're just not doing right. And then we can, pull blood work, and some of the first things that we'll see is two values, the BUN and creatinine will go up.
I think one of my big indicators is like you show me an inappetent horse that doesn't want to eat. And this is why, when I talk to people, we run a lot of blood work here.
Yeah.
Almost every colic we see is getting a CBC chem done because the signs of colic are inappetence. Well, the signs of kidney failure or kidney disease are also inappetence.
Yeah.
And then again, the hard part is trying to catch this on that blood work because again, if you've got 76% of your nephrons holding in, you're not going to see it.
Correct.
You lose that last one.
Then you're there.
Now you're there.
Yeah.
So inappetence, diarrhea.
Yeah, diarrhea's a big one.
When the kidneys quit working, the GI tract's like, all right, you've been taking care of me. Let me see if I can take care of you. I'll start filtering. And then you get blowout, massive diarrhea.
Yeah.
So. Yeah,
that's on there too. Inappetence is a big one. Like, especially in a skinny horse that doesn't want to eat, you're like, hold up. This doesn't make sense.
Yeah. Because that creatinine. I used to have one horse. He'd come in. He was kind of a chronic kidney case. And I always remember it. Like, I think 2.3 is normal, or 2.2 is normal creatinine.
Yeah.
And at 2.4, he quit eating. And I mean, you could almost know. It's like, oh, Magic quit eating. Creatinine's up.
Yeah.
And then as soon as it came down below 2.4, he's like, yeah, I'll eat. I mean, you knew what his blood work was doing based on whether he wanted to eat or not.
Well, and the kidneys are so important in filtering toxins and filtering, waste materials from the bloodstream and from the GI tract and all of those things. And when it doesn't filter that, when it stays in the bloodstream, you've got all these toxins floating around, and it makes them feel like garbage.
Yeah.
Like they really do. They feel terrible.
You watch them when they change. We'll talk a little bit about treatment when we get them on fluids. I mean, the change is pretty remarkable.
It is, yeah.
So yeah, let's talk a little bit about blood work. So we've got some things that are making us suspect for kidney disease.
Yeah.
So we're going to run that CBC chem. What's the two things? We got two things that just really make us say, hey, this is it.
Yeah, BUN and creatinine are big. When they increase it's called azotemia. You've got, if you get into the weeds about it, you've got pre-renal causes, so before the kidney causes of azotemia. You've got post-renal causes, so after the kidney causes of azotemia. Dehydration can cause that.
And you get renal causes.
And then you got renal causes, which is where we're at. So you kind of have to work through those things, but when we see those BUN and creatinine levels elevated, then we start to go, oh crap. We need to figure out, is the horse adequately hydrated? We'll correct that first. And then, do those values come down? Do they respond to our fluid therapy? And then another big thing that we'll look at is an electrolyte panel. So we'll run another little test that we call the LIGHTS panel, and it looks at specifically those electrolytes: sodium, potassium, chloride. I know I'm missing a couple that are on there.
Calcium. Yeah,
calcium. And so we'll look at those, and we'll look at the ratio of all of those electrolytes because they're supposed to be in a kind of a balance. And when those start to get out of balance, we're like, okay, something's not working here in that kidney.
It kind of gives us an idea of, as we if we go back to episode 1, we talked about glomerular filtration, we talked about Bowman's capsule, then we talked about the rest of the nephron. And
reabsorption and secretion. And
and we go through where those electrolytes go in and out at. So your vet's going to say, we need to get you on fluids because these two values are up. And like I said, that's not a recommendation. Because at this point in time, I always say we have two goals we got to figure out. One, what's causing the kidney failure? But two, we have to keep them alive long enough
to figure it out. Yeah.
And so the first step is we got to get our kidneys working again.
Yeah. Because these guys can tank so fast.
Yes.
Yeah.
This is not, because again, you've already lost 75% of your kidney function to see this go up.
Yeah.
In a renal azotemia.
Yeah. And remember that those, like we talked about in episode 1, when those nephrons are gone and they're past the point of no return, they don't come back.
No.
They don't regenerate. They're not cool like the liver in that way.
Yeah.
Yeah.
So this is where we got to focus on how do we protect this kidney.
Yeah.
So, and if you're dealing with a pre-renal azotemia, your nephrons can still be functioning, but you're producing toxins at a very, very high rate.
Yeah.
So a lot of times this involves muscle breakdown. So when we see that creatinine, if you've ever lifted weights, everybody knows about you got to get on that creatinine, right? You got to get on the protein powder and the creatinine. Or creatine, I guess.
Yeah.
Creatine. But yeah, creatinine, and then also ammonia is a byproduct of protein breakdown, which can be a problem. So a lot of horses with a muscle issue, extreme dehydration, that's going to cause that pre-renal azotemia, where you're going to see that increase in creatinine and BUN. So we got to get that stuff, because sadly enough, those are toxic to kidneys.
Yes. Well, and that's a big thing when we talk about, like, the PSSM episodes and things, like muscle breakdown and myoglobin goes to the kidneys, and that can mess the kidneys up. Like, that's a big protein that can really wreak some havoc on the kidney and cause some damage. So, we've got to stay on top of all these things. Yeah.
So those are up. Our first goal is to get them down, and the best way to do that's we'll talk about later, but flushing them out with fluids.
Yeah, lots and lots of fluids. Yeah. Other things that we can do to look at kidney function is to actually get a urine sample. We want to get a urine sample, before we start fluids, and then after we've been on fluids, and then after we come off of fluids, hopefully. But you're looking for things that are not supposed to be in the urine, like protein. Protein's not supposed to be in the urine. So if you have proteinuria or protein in your urine, that means that you have lost glomerular function. Those filters are just open and letting those proteins out.
They're not filtering, they're just letting everything through.
Correct. Yeah, and so that's not good. Glucoseuria can also be bad. The body wants to keep glucose, but the protein is the biggest thing. And then also your USG, or your it's an estimate of your urine solute concentrating ability. So how concentrated can you get that urine, or is it just flowing out, just dilute and not concentrated at all? So we can look at all those things, and kind of, it's a big puzzle that we have to put together. But also, like Dan said, trying to keep that horse alive and functioning enough to put all the puzzle pieces together is a challenge. Yeah,
step one, we got to keep the horse alive.
Yeah.
Step two, we got to figure out what's causing this and get that reversed.
Yeah.
And urinalysis, I love a fractional excretion. That's one of my favorite tests to run on these guys. Because it gives us so much information. And once you kind of know what part of the kidney's not working, then you can start to backtrack, and you can figure out, okay, what's causing this?
What insult did we have? There's different drugs, there's different things that can affect different parts of the kidneys, and you can kind of like go back in time and say, okay, did we have any of these things happen? And was that our kind of catalyst?
I always say my view on everything, I try to keep things really simple, C+ student here. So my thought is, like, one, keep them alive long enough to figure out what the cause.
Yeah.
Two, you can't get better till you stop getting worse.
Yeah.
So then I start focusing on, where's my primary cause?
I need to make that a bumper sticker.
Yeah, you can't get better till you stop getting worse. So that's like my first goal. How do we stop getting worse?
We just need a T-shirt of Danisms.
Yeah, so that we gotta go find the primary cause, because if we don't find that primary cause, we can't stop them from getting worse.
Yeah.
And like I said, before you can get better, you gotta stop being worse.
Yeah.
So stopping that primary cause, and so knowing, because there's so many different things that can affect them, is knowing what that is that set us up for this to begin with.
Yeah.
So when that BUN and creatinine goes up, we're gonna diurese these horses. And when I say diurese, what I mean is a massive amount of fluids. Like, their shavings are going up.
Oh yeah.
Like, there's a lot of
we need them to be like flooding their stalls.
Yes.
Like, we want to flush them out. We've got to run them fluids 24/7. Like, I mean, literally flush them out. And when I say it's hundreds of liters, I am not exaggerating.
No.
Because we hang 20 at a time, and you're changing those bags every couple hours. I mean, you are flooding them.
To give you an idea, most of the colics are running, about 2 liters an hour?
Yeah.
My kidney cases, I'm pushing 4.
Yeah.
I'm doubling the fluid rate.
Yeah.
And 2 liters an hour is already above maintenance.
Yeah.
Where they need to live, and we're going to double that.
Yeah.
I mean, a lot of fluids.
It's a lot.
So we want those kidneys just pumping.
Yeah. But yeah, and getting them to eat again is also important. Like we've got to get nutrition coming in and trying to keep the rest of the body happy, and it's a hard balance to find sometimes.
Because they're not going to start eating until that BU and creatinine comes down. Till that starts to come down, and we don't have the cool tools, right? If we hook them up dialysis, fantastic.
Cool, easy.
Yeah, the closest thing we've got is peritoneal dialysis, where you put a belly drain in, and you just run a crap ton of fluids through the GI tract and hope it just
hope
brings some of it out.
Hope is the key word there.
Yeah, and I always say hope's not a plan, but
yeah,
peritoneal dialysis is kind of hoping our way through.
I've never actually seen one of those to be.
I've done it.
Yeah.
It wasn't successful. It was like most severe kidney cases, the kidney quit working. It's not. Again, because it's tied to everything. Literally
everything. Yeah.
So.
But yeah, so you can have different types of kidney damage and different types of kidney failure. But one that's common that we run into a lot is the proximal tubule. That's where a lot of drugs get secreted, and so proximal nephritis or inflammation of those nephrons in the proximal tubules are it's common. So a lot of that is drug induced. So you've got your NSAIDs, non-steroidal anti-inflammatories can wreak havoc on those kidneys there and this is at like prolonged high doses.
Right.
When they're used appropriately, we make dosing schedules the way we do for a reason, because we know about how much the kidney can take, and we try to not push it. Antibiotics, some antibiotics, particularly the aminoglycosides like gentamicin, amikacin. Those guys they're tough on the kidneys.
Fantastic antibiotics, but again, that's why when we pick them, we know this is a known risk. We look at things saying, okay, our kidney function is good.
Yeah.
This is the right horse. He's, young to middle-aged horse.
Yeah.
Kidneys are working great. We're going to pick this antibiotic based on that.
Yeah. And that's another reason why, like, when we need to pick an antibiotic and we ask to run blood work first, or we recommend running blood work first, this is why.
Right.
Like, it's not just... Antibiotic selection is not just about the antibiotic and the bacteria that we're trying to kill, but it's also about the rest of the horse.
Because it doesn't do us any good if we kill the bacteria and kill the horse.
That's not great.
We have not won this game.
No, nobody wins. So it's really important. Like these tests that we want to run, these diagnostics that we want to run before we make decisions, they're very important.
Mm-hmm. Well, the thing is people forget the dose determines the poison. And so the right medication in the wrong scenario can be detrimental. It goes from being a medication to a toxin. Mm-hmm. And so making sure we navigate that and know what we're getting into, especially, like I said, the aminoglycosides.
Yeah.
And NSAIDs, not only do they hit that proximal tubule, but they also mess with renal blood flow.
Yes.
Because prostaglandin is important for renal blood flow.
Mm-hmm.
So when we turn off prostaglandin,
yeah,
that's when we lose blood flow to the kidney, and we can start to get kidney damage from that.
Yeah, and this is like when we talk about, butanbanamine versus another NSAID like Equiox or Ferrocoxib. Prostaglandins come in two flavors, good prostaglandins and bad prostaglandins. Mm-hmm. A lot of your NSAIDs just knock out all prostaglandins.
Yeah, they're non-selective.
Right, whereas Equiox is more of a selective COX inhibitor. So if I talk to people a lot about, this is safer long term. It's not, nothing's 100%, but it is safer, and this is why. We always have to think about these things, though, and every time we dose these medications, in the back of our minds, we're like, okay, thinking about my kidneys, thinking about my liver, thinking about my GI tract, thinking about, all the other things that go into it, and just making good decisions for the whole horse.
Well, and that's a very important point. Is I always say this is why R's are important, because Equiox is safer.
Safer, yes.
But there's still an R on the end of that word.
I still check blood work once a year on those guys.
Because, yes, it is selective for COX-2, which is the bad prostaglandin. It gets rid of it, but it still has some COX-1 activity. And that COX-1 activity is what works on the stomach to produce mucus. So we inhibit that. We quit making mucus in the stomach.
Yep.
And then we also start decreasing renal blood flow. And so it does have side, and it still has less effects on the proximal tubule, but again, safer.
Safer, yes.
Safer.
Yeah.
Not a supplement. It's not without side effects. I have seen renal damage with it. Like I said, if you look at the studies, all testing was done for 14 days.
Yeah.
Now, we don't want to scare you out of using it. There's a time and a place.
Yeah.
And like I've been there with some of these older horses, and even the Equinox isn't cutting it, but a gram of bute twice a day keeps them going.
Go for it.
They're in their mid-30s.
Yeah.
And it's like, you know what? If
Roll
our
the
kidneys
dice.
get us, our kidneys get us.
Yeah.
But this is what keeps them comfortable, so we're going to do that.
Because quality of life is important.
Right.
So,
yeah, this is when we just roll the dice.
yeah.
Same thing, we get some of these infections. We got one antibiotic that's working, and that's
gotta go for it.
gentamicin. Yeah, I don't know what's going to happen to the kidneys, but I know what happens if we don't. So,
Yeah.
yeah, it's, you know, another cause that I think about other than just medications, and I see this a lot, is primary muscle damage,
Yep.
primary
yeah.
muscle disease.
Yeah, you have a horse that's tying up, or you have a horse that just has a lot of muscle damage. Those muscles release myoglobin, and that goes and gets filtered by the kidneys. But like I said, that's a large protein that can really damage those kidneys. And then you get your kidneys end up turning like, or not your kidneys, your urine ends up turning like this like brown color.
Yep, myoglobinuria.
Myoglobinuria, yeah. And that is, if we see that on a horse that was tying up, you're like, oh crap, we gotta fluids. And this is why if we have a horse that's tying up, or we have a horse that's having a lot of muscle damage, or we just suspect that there's a lot of muscle damage, running those fluids preemptively to help flush that out is gonna be huge.
The big things we see there is you've had an episode where your horse got really stiff during exercise, and we run blood work. We'll see another enzyme, CK, creatinine kinase. Now that's different than creatinine.
Yes.
But creatinine kinase will be up, or AST will be up.
Yep.
And we'll say, hey, we need to get this horse on fluids. Some of it's to get the toxins out of the muscle and make sure we're getting good blood flow to the muscle by expanding blood volume. But a big thing is protecting that kidney.
Yep.
Because the body will get rid of the CK and AST. Like, it's going to recover from that.
Yeah.
But our kidneys are over here screaming.
Yeah.
And if we lose kidneys,
We lose the horse.
yeah, we don't have kidney transplants.
No.
And once you lose it, it's gone.
Yeah. I've had a couple cases where, systemically the horse seemed fine, but it was either cast for a very long time and struggling, or, had some serious trauma. And I was like, okay, we're going to run fluids. And I mean, it makes a world of difference.
And I've even seen it with horses getting a fight in the pasture, and they get a lot of muscle damage from being kicked. But it's like, I think most commonly it is that horse that's been down for a long period of time.
Yeah.
Losing blood flow to those areas. And that's where we talk about reperfusion injury. We start reperfusing these, we may run blood work on them at the beginning and everything looks good, but when we start hydrating them and moving all of that CK and AST out, our kidneys get hammered pretty quick.
Yeah.
So we're monitoring those serially in the hospital and knowing where's everything at.
Yeah.
So another cause is in these strange cases where we get what's called intravascular hemolysis. So this can happen with red maple toxicity.
Yep.
And we start to get lysis of red blood cells. And so that same myoglobin that was released from the muscle, well, the red blood cells have one.
Called hemoglobin.
Hemoglobin.
Yeah.
A lot of times when the words are the same, they're really similar in structure.
They both carry oxygen. One just carries oxygen in the red blood cell. The other one carries oxygen in the muscle. That's the only difference.
That's it.
Ta-da.
One of them's more efficient. Yeah. Shocker, right? They named them similar. They probably have similar functions. So when you see that, you'll see that the bilirubin goes way up.
Bilirubin is a byproduct of hemoglobin breakdown. Yeah.
And again, that's not real great for the kidneys. So we may look and be like, he has no red cells. His hemoglobin's way up.
Yeah.
We need to protect the kidney. Like you'll find out we protect the kidney at all costs.
Oh, yeah.
The kidney must be protected.
The kidney must live.
Yes.
Yes.
Must live. The liver will fix itself. That's its superpower.
Yeah. If you help the liver and just give it time and don't overwork it, it can fix itself. Kidneys?
No.
No.
Their superpower is they control everything.
Correct.
The liver superpower is it can rebuild itself.
Yeah.
So yeah, that's another one. We see that T-Billy, total bilirubin. We see that up. We're like, need to watch out for my kidneys.
Yeah. Yeah, there's, and like I said, that's why this blood work is so important because, maybe your kidney values are normal, but we can see indicators on there that in the future they might not be.
Right.
So we're trying to prevent that. We're trying to prevent getting into that snowball situation where we're out of time and we're out of options.
Right, because, that's the thing. You lose enough of it and you're
done.
We're done.
Yeah.
Another one that I think about is leptospirosis. Thankfully, we don't see a ton of that.
We don't.
But it's a bacteria that can cause pretty acute kidney damage.
Yeah.
So, but thankfully, like I said, don't see a lot of it. There's other congenital causes.
Yeah, there are. Polycystic kidney disease in horses is a thing. Your kidneys, cows' kidneys always look like this.
Right.
Which is kind of crazy. Cows are weird. But they look like a bunch of grapes almost.
Yes.
Which is bizarre. Horse kidneys are like smooth and normal kidneys.
They're actually quite beautiful on ultrasound. When you see a normal kidney,
they are.
It's really a beautiful structure, clearly delineated.
Yeah. Everybody makes fun of me because when I get like a good kidney shot, I'm like, ooh, it's so pretty. And they're like, what is wrong with you? I'm like, look at it. Look at it.
Kind of want to put them on the wall sometimes. There's some of those images like, can we frame that?
So pretty.
But yeah,
anyway.
They look like a cluster of grapes.
Yeah.
And the worst part is we don't usually find it. I always say PKD shows up at the worst possible time.
Yeah.
It's when these horses are really starting to do well in their careers. They're really starting to perform, and then all of a sudden, typically I see a drop in performance, a drop in weight, inappetence and weight loss is a big
one. And these are younger horses that we're talking about now. Yeah.
Like, I don't know, 4 to 8.
Yeah.
Like,
and they're just not doing, and you're like, why the heck? I've dewormed this thing. I've got it on a great plan of nutrition. We've been going really good, and then all of a sudden they just.
Right.
Yeah. And it's not something that you normally look at when you're doing like a normal horse like workup. Like it's.
Well, no, because thankfully it's a pretty rare condition.
It is rare.
I've seen a handful of them. And again, it's as soon as because we didn't really talk about that, but as soon as we see those kidney values being elevated, not only are we getting them on fluids, we're reaching over, we're grabbing an ultrasound machine, and let's go look at the kidney.
Yeah.
And if we look in and see that kidney looks like a cluster of grapes. I always say it kind of looks almost like a blackberry.
Yeah.
Looks like a giant blackberry.
Yeah.
Because everything's still held really tightly together, but it has all these lobules in it. So.
Yeah. Basically, with the polycystic kidney disease, you have all the tissues there, but it's not functional.
Right.
Because you've just got all these little lobules of non-functional tissue, essentially. So your amount of nephrons is way lower than in a normal horse, and they're not functioning. And so they run out faster.
So as soon as you lose the few that were working, the rest of them are just done.
Yeah.
And we don't have a cure for it. And then sometimes you can just have a congenital malformation where your kidneys don't develop. We had that in here a few weeks ago. And the kidneys just didn't develop. It was a 2-year-old horse, ill thrift, poor doer, and it just had no kidneys.
Yeah.
And
it happens.
Nothing we can do.
Yeah, that happens. The same thing happens in dogs as well. They'll be born with one teeny tiny little kidney and then one normal kidney, and that normal kidney gets huge because it's trying and working and doing everything it can. But at some point, you just can't. You can't go anymore.
Yeah.
So.
And then people always ask about this one. That's toxins.
Yeah.
But I think I've seen one. And the one that were highly suspect, it was an acute renal failure, had all the symptoms of acute renal failure. I never did find out what the toxin was, but I do remember there was an old barn on the property. And it used to be an old cotton farm.
Yeah.
It was up in Tennessee. It was an old cotton farm, and we're 90% sure acute renal failure, and it was non-recoverable.
What is it? Is it Gossipol?
Gossipol is what we were suspect of.
Dang.
Yeah.
Yeah, toxins are not one that's super common. I have seen a couple cases of, well, I should say one case of, we suspected a liver toxin, and then we got basically amyloidosis, which is serum amyloid A, which is the SAA test that we run, got sky high. And when that amyloid goes and deposits itself in places, sometimes it deposits itself in the glomerulus in the kidney, and then your filter's gone. And that's what happened to that horse. So indirectly a toxin, most likely, but the pure renal toxins are not common, thankfully.
No, I'm pretty thankful. I think most of the true renal toxins come from us.
Drugs, yeah.
They usually come from medications.
Yeah.
The other one, and thankfully we don't see this one much anymore, is blister beetle toxicosis, cathardin.
Yeah. Gosh, I haven't thought about that in a hot minute.
I know. I'm always on the lookout because I'll never forget the first one I saw was in vet school.
Well, because it was common in Kentucky.
I didn't see it a lot in Kentucky, but we had a barn here in Georgia that I'll never forget. It came in, and Dr. Welchel, that was actually on earlier, she was the one that she was the resident on the case.
Yeah.
And I remember she's like, "There's only two things to do this. One of them's this. Do you have alfalfa hay?" And he goes, "Yeah." "Where'd it come from?" "Arizona." And she's like, "Oh crap."
Yeah.
Because this is a beetle. It's mainly in the southwestern United States, and like a quarter of this beetle, if they eat a quarter of this beetle, it's enough to cause severe renal failure.
Yeah.
Also causes gastrointestinal signs. They're calcium tanks. And I'll never forget that case because he had 20-something horses affected.
Dang.
Off a load of hay because it's a beetle that infests alfalfa hay, but it's mainly in the southwestern United States. And now I think they're vigilant, surveying these fields, spraying these fields. They're vigilant because, like I said, a quarter of this little tiny beetle is enough to completely just strip the tubules of any resorptive function whatsoever.
It's crazy.
It's wild. Crazy. And I mean, then the toxin gets into the bladder and it strips the whole line of the bladder. The urethra starts to have issues. I mean, it is a terrible, terrible toxin.
Yeah.
So I think it has medicinal purposes in China or something, but
not for horses.
Not for horses. So yeah, that's another one that I've seen renal failure with.
Yeah.
But yeah, so when we get into treatment, we're treating these cases. Like I said, fluids is number one.
Yeah.
Lots of it.
Lots of fluids.
Lots of fluids.
Yes. Fluids, rechecking blood work, kind of monitoring those values. I always look at PCV, so the pack cell volume. Are we able to retain the fluids when we need to?
Yes.
Because if our PCV starts high, say it's like 50 something, and I've run fluids and I have diuresed this horse and I have rehydrated them and their PCV is still at 50, that means we're not reabsorbing water. We're
dumping water.
We're just dumping.
Or if you're doing that and you start to see edema and you've got protein in the urine, it means your filtration's just
gone.
Shot.
Yeah. So, like I said, it's a big puzzle, which, sadly most of the time these cases don't end well. But for me, in my little internal medicine brain, like these puzzles for me, when I get to put all these pieces together and I'm like, whoa, like that's my dopamine hit. Like that's what keeps me going. But, I'm just crazy because they don't end well, but I love it.
I always end up with a whiteboard I end up drawing a whole nephron on this whiteboard.
Yep.
And then mapping everything out and say, okay, what part of this isn't working? Because then we can backtrace and say, okay, this is the part of my kidney that isn't working. Yeah. This steers me to this is what's going on and allows me to sort through what I need to do next.
Yeah. Yeah, but it's truly our options are very limited in these cases, and they're very frustrating because, there's so much that we want to do, but we just...
I mean, we basically can diurese them on fluids, and then it's supportive care. If they're losing electrolytes, getting the electrolytes back in them.
Yeah.
If it was like an NSAID toxicosis, like somebody messed up and gave, and this has happened before.
Oh, yeah.
the little plunger on the tube of bute slips, and they get 20 grams instead of 1. This is one of those things like, hey, get them in here now. But I have put those on the synthetic prostaglandins, like a misoprostol, to help out. At least I can help out with the blood flow issue and try to counteract the anti-prostaglandin activity.
Yeah, because if you lose blood flow to the kidney, then you lose filtration and you lose just the health of the kidney itself. I mean, it doesn't. The kidney does a lot to protect its own blood flow. Like it does a lot to maintain that blood pressure in those afferent, efferent arterioles. Like it has a lot of mechanisms to protect itself. But when those mechanisms are overridden, it's a bad day.
Yeah.
Yeah.
So yeah, that's the downside. That's why I always say, like, if we can prevent this, catching it early. I think a common thread in all of medicine ought to be like, catch it early. The sooner we catch things, usually the easier they are to treat, the more likely we are to treat them.
Yeah.
And the better success rate we have.
So if your vet, like, if it's something that seems completely non-kidney related, you're like talking about something completely different, muscle, drug, something, and they say, hey, I'm worried about kidney function. We need to run blood work and run fluids. Do not fight them on it.
No.
Please.
Because again, as we talked about in episode 1, everything's connected to the kidney.
Literally everything.
So anything that happens in the body can go back to the kidney. So, and again, once we lose it, we don't get it back. Like liver toxicity, everybody's like, oh, what about the liver? Like, I'm not worried about the liver. That thing its superpowers, it heals itself.
You just have to help it through.
Right.
Yeah.
You just gotta support it.
Yeah.
The kidney, when we lose it, it's gone.
Yeah.
And then, like I said, the entire system is affected when that's gone.
And those horses, again, the warning signs is they're very lethargic, they're very tired, they have poor performance, weight loss, they don't want to eat, they just look bad, and they feel terrible. And so, it's not a pleasant way to go. So.
And like I said, and the other important part is sometimes it may take repeat chemistries to find this. It may not be a one and done test.
Oh yeah.
And it's not like we're just running and hoping. It's that we're highly suspect in here. We don't have the smoking gun yet. And there may be times where like this thing screams kidney. What happened makes me very concerned about kidney. Let's just get them on fluids.
Yeah.
And we may not even have those elevated values yet, but if we can protect that kidney, save those nephrons, we're in a lot better shape.
We live to fight another day.
Yes.
Yeah.
So.
Yep.
The magical world of the kidney.
Yeah, they are a world unto themselves.
I know. Nobody ever thinks about them.
I mean, I do, but.
Yeah, I mean, I think about them all the time.
Normal people don't, I guess.
Like I always think about, every time I talk about kidneys, all I can think about that Friends episode where Joey's in there. It's like, it's a kidney stone. No
Those
doubt.
are miserable, let me tell you. Oh, we didn't even talk about that.
Well, thankfully, we don't see a ton of those.
We don't see a ton of them. That's why we didn't even think about it. But yeah. Horses can get kidney stones too. It's just not very common.
No,
they're very good at dumping out their calcium. So.
No, I've never seen a kidney stone. I've seen a lot of bladder stones.
Well,
a lot of sludge in the bladder,
Lots
but
of sludge.
Thankfully, no kidney stones. But yeah, the kidney. Don't forget about your horse's kidneys.
Please.
They're important.
And if your vet says, hey, I'm worried about the kidneys, don't argue.
No.
Just say yes to fluids.
They know we got to lose a kidney and a half.
Kidney and a half.
That's the worst part. It doesn't say help until it's too late.
It's a toxic work environment for a kidney. Yes. Really. They're just drowning constantly, and they're like, it's fine.
We're good.
We're good.
All's good. All's good. I got this.
Yeah.
Yeah, and then, like I said, medications don't come without harm.
No, and I don't want this episode to scare anybody from using medications correctly. Yeah. Like, they are good when they're used correctly, but no medication is benign.
Yeah, because we use a lot of NSAIDs. We use a lot of tetracyclines. We use a lot of aminoglycosides. They're great medications.
Yeah.
But like I said, they do come at a cost. And that's why it's really important to know what those costs are. Yeah. Because those are the things we need to watch out for. Yeah. Like, I've gotten some of these derm cases where the only thing it's sensitive to is gentamicin. And I know this is fixing to be a 2-week course of gentamicin.
And that's tough.
Yeah. So my spidey senses are already up. We're checking the kidneys. Like, we're going to check them when we start. We'll check them about a week in. We'll check them when we get done.
Yeah.
Like, we want to know, like, hey,
how we doing?
How we doing here?
Yeah.
And age of the horse matters too, because as we age, we lose kidney function just in general.
And there's some horses, like if I'm going to put them on a long course of NSAIDs, or I have to, like I'm going to be more worried about GI effects than I am kidney effects.
Right.
Based on the rest of the signalment of the patient. But it just is knowing your patient and knowing, what the risk factors are, and then planning appropriately.
Yeah, looking at age, do they have a history of a neuromuscular condition? Have they tied up in the past? All these things play a role. That's a good medical history.
So important.
Yeah, I tell people all the time, like when you come in, this is not time to play stump the veterinarian. Lay it all out there, because it's always that one fact. Have you ever noticed that?
Yeah.
It's like, well, I didn't know if this would be important or not.
You'll have a whole plan laid out, and then they say, oh yeah, by the way, this one thing happened, and I'm like, hold up, what?
Yeah.
And then you change the whole plan.
It's like, I don't know if this is important. Like, you kidding me? That was the key that unlocked the whole puzzle. Like, that's what I needed to know.
Yeah. And sometimes you'll be like lost in the sauce, and you'll be like, none of this makes sense. Yeah. And then they say one thing, and you're like, oh, okay.
Now it fits.
Now I got it.
Yeah. So don't play stump the veterinarian.
Please give us all the information you have.
We don't care. Just ramble. We'll sort out what's important, what's not. And if you're getting a second opinion on something, never use the words like, hey, I don't want to give you too much because I want to see what you come up with. I don't want to skew your thought. You're not going to do that.
To. No.
No, we're trained.
We're very stubborn.
Yeah, we're going to think through this.
Yeah.
You're not going to mess us up. We need all that information.
Yeah.
Like if we're trying to figure out what's going wrong and you don't want to tell us that your horse is tied up like 18 times in the last 2 years.
That's kind of important.
That's really important.
Yeah.
Very, very important.
Yeah.
So
Kidneys.
Yep. Thanks for being here today. Thanks for talking about kidneys. I love the kidney.
Happy to do it.
I remember when I took renal physiology in vet school, Dr. Scott Brown taught it. He's like, the kidney is everything. I was like,
it really is.
It's a stupid kidney. How important could it be?
Like I said, I hated it when I was an undergrad. I was like, man, this stuff is confusing. It's so hard. And then I got to vet school and I was like, whoa.
Yeah, this is the guy.
This is crazy.
He is the organ that runs all things.
Listen, if you love your kidneys will love you back.
Yes. So be good to your kidneys.
Yeah.
Be good to your kidneys.
Drink water. Don't drink caffeine like I am. Just put it down under the table.
I love my caffeine.
Yeah.
Coffee. I always say water's an ingredient.
Water is the most important nutrient.
Yes, it's a very good ingredient. I like to mix things with it.
like coffee beans.
Yes, coffee beans. Tea.
Oh, gosh.
Yes,
all right.
Well, thanks for being here today. Thanks for all the people that helped make this podcast possible. Casey, thanks for editing this. April, thanks for recording, doing all the work to make sure that this podcast gets off to a great. Just make sure it just happens.
It gets off. It just goes.
Yeah, she makes sure it happens. So thanks for all the doctors here at Countryside willing to jump in, all our guests that come on, and most importantly, thanks for our listeners. If you like this podcast, like and subscribe. I'm trying to remember to do that. I got to remember to tell y'all like and subscribe. I think, is that what I'm supposed to say?
I think so.
Yeah.
I just never thought those words would come out of your mouth.
I know. And if you don't want to like and subscribe, don't like and subscribe. We're not doing this for anything, but we want to get the world educated. That's really about the only reason we do this.
Well, it's also fun.
It is kind of fun. I mean, come and nerd out. If you're a nerd, this is a good time.
Yeah.
And we got to nerd about kidneys, which we don't get to do that often.
For 3 whole episodes.
I know. Love kidneys. So, again, if you love your kidneys, the kidneys will love you back.
That's
Y'all
correct.
have a great day. Take care.